Hi everyone, welcome back to Doodle Nurse. In this video, we're doing a complete nursing review of the respiratory system. We will break down how the respiratory system works, the common respiratory disorders that you will see in your clinical practice, how those conditions are diagnosed, and the treatments that nurses are directly involved in managing. We will start with the foundational concepts because understanding normal physiology makes abnormal findings much easier to recognize. Then we'll move through obstructive lung diseases like asthma and COPD, restrictive conditions like acute respiratory distress syndrome, then the infectious processes like pneumonia and tuberculosis, and finally the life-threatening respiratory emergencies. By the end of this video, you should be able to confidently connect patient symptoms with the diagnostic findings, understand what's happening physiologically, and prioritize nursing interventions to keep your patients safe. The respiratory system has several critical responsibilities that support our overall homeostasis. First, it delivers oxygen into the bloodstream. Then, oxygen is essential for cellular metabolism and ATP production. Without it, organs begin to fail quickly. Second, the respiratory system removes carbon dioxide, which is a waste product of the metabolism. Carbon dioxide then directly affects the blood pH, so even small changes in ventilation can rapidly lead to acid-base imbalances. This is why respiratory disorders can cause respiratory acidosis when carbon dioxide is retained, or respiratory alkalosis when the carbon dioxide is blown off too quickly. Finally, the respiratory system plays a key role in our immune defense. Mucus traps particles and pathogens, then cilia move debris upward and out of the airway. Alveolar macrophages engulf and destroy the microorganisms, so when these defenses fail, infection risk increases. Our respiratory system is divided into upper and lower airway. The upper airway includes the nose, nasal cavity, pharynx, and larynx. These structures filter, warm, and humidify incoming air while also serving as protective barriers. The lower airway begins at the trachea and includes the bronchi, bronchioles, and the alveoli. Here's a key nursing concept. Gas exchange only occurs in the alveoli. That means no matter how fast or deep a patient is breathing, oxygenation will only be impaired if the alveoli are filled fluid, inflammation, mucus, or collapse. This explains why conditions like pneumonia, pulmonary edema, ARDS, and cystic fibrosis can cause severe hypoxia even when the airway itself is open. Normal respiratory assessment. In a healthy adult, the normal respiratory rate is 12 to 20 breaths per minute. Oxygen saturation is usually 95% or higher, though this must always be interpreted in the context of the patient's baseline and chronic conditions. Normal breath sounds should be clear and equal bilaterally, with symmetrical chest rise and relaxed unlabored breathing. Red flags include accessory muscle use, nasal flaring, retractions, tripod positioning, or tachypnea. These signs indicate increased work of breathing and may appear before even oxygen saturation drops, making them critical early assessment findings. Common abnormal respiratory findings include dyspnea, wheezing, crackles, stridor, and cyanosis. Wheezing suggests narrowed airways and is most often associated with obstructive disorders like asthma or COPD. Crackles indicate fluid in the alveoli or alveolar collapse, commonly seen in pneumonia, pulmonary edema, fibrosis, or heart failure. Stridor is a harsh, high-pitched sound heard on inspiration and it also signals upper airway obstruction. This is a medical emergency. Cyanosis is a late sign of hypoxia, and if cyanosis is present, the patient is already critically hypoxic and requires immediate intervention. In this slide, we'll talk about obstructive versus restrictive. Obstructive lung diseases are characterized by impaired airflow, particularly during the exhalation. The primary issue is increased airway resistance, which leads to air trapping and difficulty moving air out of the lungs. While restrictive lung diseases limit the lung's ability to expand during the inhalation, this results in reduced lung volumes and stiff lungs. Example is the ARDS or acute respiratory distress syndrome. It is a severe inflammatory lung condition characterized by acute onset of respiratory failure, refractory hypoxemia, and decreased lung compliance. Asthma is a chronic inflammatory disorder of the airways. It's characterized by bronchoconstriction, airway edema, and an increased mucus production. Patients commonly report wheezing, chest tightness, coughing, and shortness of breath, often worse at night, early in the morning, or even after exposures to triggers like allergens, cold air, exercise, or respiratory infections. A defining feature of asthma is reversibility. So, with proper treatment, airflow obstruction improves, distinguishing asthma from COPD. Status asthmaticus is a medical emergency that occurs when a severe asthma exacerbation does not respond to initial therapy. As airflow worsens, patients may become exhausted, air movement decreases, and wheezing may disappear entirely, resulting in a silent chest. This is a sign of impending respiratory failure. Treatment includes continuous bronchodilators, systemic corticosteroids, supplemental oxygen, magnesium sulfate in some cases, and preparation for intubation if ventilation cannot be maintained. For asthma diagnostics, pulmonary function tests are the cornerstone of asthma diagnosis. Findings typically include a reduced FEV1 and a decreased FVC ratio that improves after bronchodilator administration. FEV1 is the forced expiratory volume in 1 second, while FVC is the forced vital capacity, which is the total air exhaled forcefully. The peak expiratory flow rates are useful for monitoring disease control and detecting early exacerbations. When the diagnosis is uncertain, a methacholine challenge test may be used to provoke bronchoconstriction. Pulse oximetry and arterial blood gases assess the oxygenation during the acute attacks, while the chest x ray is usually normal and helps rule out complications. COPD is a chronic, progressive disease characterized by irreversible airflow limitation, most commonly caused by long term smoking. It includes two main components: chronic bronchitis, which involves mucus hypersecretion and inflammation, while emphysema, which involves alveolar destruction. Unlike asthma, airflow obstruction in COPD is not fully reversible. The gold standard for diagnosing COPD is pulmonary function testing. Results show a decreased FEV1 and FVC ratio below 70% that does not improve with bronchodilators. Arterial blood gases may reveal chronic carbon dioxide retention, particularly in chronic bronchitis. Chest x-ray often shows hyperinflation and flattened diaphragms, while chronic hypoxia can lead to polycythemia on CBC. COPD treatment includes bronchodilators, inhaled corticosteroids, pulmonary rehabilitation, and vaccination. Smoking cessation is the most important intervention and is the only measure proven to slow disease progression. Oxygen therapy is prescribed for chronic hypoxemia, but it may be carefully titrated to avoid suppressing respiratory drive in carbon dioxide retainers. Nutrition support is also essential as many patients experience weight loss and muscle wasting. Restrictive lung disease is a reduced lung compliance and limit expansion. One example is the acute respiratory distress syndrome. An acute, life threatening inflammatory process that leads to widespread alveolar flooding and severe hypoxemia. It does not respond to oxygen therapy. Management of these includes the lung protective mechanical ventilation. It has to have high PEEP, prone positioning, and treatment of the underlying cause. Pneumonia causes inflammation and fluid accumulation in the alveoli, impairing gas exchange. Patients typically present with fever, productive cough, dyspnea, and crackles. Tuberculosis is a chronic airborne infection marked by persistent cough, night sweats, unintentional weight loss, and hemoptysis. Treatment for pneumonia are oxygen, antibiotics, and supportive care. Remember, no inhalers for pneumonia because this is a bacterial infection. For TB, this requires a prolonged multi-drug therapy and strict airborne precautions to prevent transmission. Always remember to have N95 mask for this. RIPE therapy stands for rifampin, isoniazid, pyrazinamide, dambutol, and this is the standard first-line treatment for active TB. Flu is usually viral and common in children. Swelling of the upper airway produces a barking cough and inspiratory stridor. Viral infection commonly caused by parainfluenza virus, while epiglottitis is a true airway emergency. Primary cause is the bacterial infection, commonly the Haemophilus influenza type B or Hib. Patients present with high fever, drooling, dysphagia or difficulty swallowing, and tripod positioning. The airway must be secured immediately. Throat examination should be avoided to prevent complete obstruction. Vascular and pleural disorders, these are the pulmonary embolism, pleural effusion, and pneumothorax. Pulmonary embolism occurs when a clot blocks pulmonary blood flow, causing the sudden hypoxia and cardiovascular strain. Patients will present with chest pain and dyspnea. Treatment for this would be heparin, TPA, oxygenation, and also turning patients on the left side for oxygenation. For the pleural effusion, this involves fluid accumulation that compresses the lung tissue and restricts the expansion. Treatment for this would be diuretics. Patients will present with abnormal breath sounds and dullness. For pneumothorax, this is a emergency. It's when the air enters the pleural space, leading to lung collapse. For tension pneumothorax, it's more life-threatening and requires the immediate chest decompression. Nursing priorities always begin with airway protection and effective ventilation. Position patients upright, continuously monitor oxygenation and respiratory effort, and also assess the mental status frequently because confusion or agitation may be the earliest signs of hypoxia. Arterial blood gases provide critical insight into ventilation and acid base status. Early recognition, though, and rapid intervention prevent the respiratory fatigue and carbon dioxide retention, and also progression to respiratory failure. Thanks for watching Doodle Nurse. If this helped your studies, be sure to like, subscribe, and share because the strong respiratory assessment saves lives.